Hello, I'm Angela Sevilla, and I'm going to be doing the abdomen exam on my mother here. So first, some pre-inspection stuff. I should recall the abdominal quadrants and also the major organs within this exam, and then also to be considerate of the GI, GU, vascular, and reproductive structures, especially with the uterus and the ovaries involved in this exam. First, I'm going to inspect, so I'm going to look at the contour. Is flat rounded, any scaphoid, and then if there's distension, which I don't note. And also I'm going to be looking at the symmetry, so looking at the musculature, and then looking if there's any bulges or hernias. Then I'm going to be looking at the skin, looking at the color, scars, if there's striae, rashes, lesions, or ecchymosis, and then vasculature, looking if there's dilated veins noted on the exam, and then also looking at the umbilicus, looking at the contour, location, and also looking if there is possible inflammation. And then with the tangential light, I would also be assessing for any faint pulsations, which are normal, but visible peristalsis is not a normal finding. Next, I'm going to be auscultating. So I'm going to be assessing for bowel sounds in all 4 quadrants using the diaphragm of my stethoscope. Sorry, it's gonna be cold. So we're gonna do here. And listening for bowel sounds. Thank you. And then with the bell of my stethoscope, I'm going to be listening for bruits or any friction rubs. So I'm going to be listening at the aorta, which is midline. And then I'm going to be listening to the renal arteries, which are just lateral to the aorta. And lastly, I'm just going to listen to the iliac arteries, which are just below the umbilicus toward midline. And I don't hear any bruise or friction rubs. Next, I'm going to be percussing. So general percussion is for tympany versus dullness. Generally, for the abdominal exam, I should hear tympany and not dullness. Dullness indicates some sort of fluid in the abdomen. So, but there is expected dullness over the liver, the spleen area, and any stool-filled bowel. Unexpected dullness may indicate a fluid mass or organ enlargement. So I'm going to just be percussing. Okay. And then we're going to be assessing the liver span. So we're going to start percussing from upward from the abdomen. And then if I hear dullness, that's the lower border of the liver. And then I would be percussing downward from the chest, and the dullness would indicate the upper border. So, and then a normal span, and then I would measure between those two, and the normal span of a liver would be about 6 to 12 centimeters. So going up. It'd be right here, and then I would percuss down. So this is the lower border, and then I would go to the upper border, and then I would measure, and it should be between 6 to 12 centimeters. Next, I'm going to be percussing the spleen. So I would start with the left posterior lateral ribs, and then it should not be palpable or anterior, and persistent dullness is concerning. So I go here, and I would percuss. Okay. Next is palpation. So we're going to start with light palpation. So we're just going to go in gentle circular motions. And then I'm going to be assessing for tenderness, any guarding or rigidity. And then I'm going to also be assessing for deep palpation. So with my dominant hand, relaxed, I'm going to use my non-dominant hand and apply pressure on top of the other. I'm going to be assessing for masses and deep tenderness, and I'm going to avoid direct pressure over naturally tender areas like the aorta, bladder, and ovaries. And generally, the spleen is not palpable. Lastly, I'm going to be doing liver palpation. So with my left hand, I'm going to lift under posteriorly of the right flank, and then with the right hand, I'm going to palpate below the lower liver border. And then I'm going to ask the patient to take a deep breath in, and then I'm going to feel for the smooth edge when it descends. And it should be smooth, non-tender, and also many livers are not palpable, but I don't notice any tenderness. And then a general note, pressure discomfort is expected, tenderness is not, and recurs further evaluation. So no tenderness was noted with the palpation part of the exam. And some special tests that we could do to assess for cholecystitis, appendicitis, and peritonitis. For example, with Murphy's, that would be assessing for cholecystitis. I would palpate the liver, and if there's pain upon a deep inhale, that could indicate cholecystitis. And then McBurney's point, so we have the iliac crest here, and then the umbilicus in between is McBurney's point. If I were to palpate and there's pain, that could possibly indicate appendicitis. Rosveen's sign is to palpate the abdomen on the right side, and if there's pain felt on the left side, that could indicate appendicitis. So as an obturator, so I would have the patient flex her knee up, and if there's pain upon that, that could possibly indicate peritonitis. And I'll have her flex her knee again, and then internally and externally rotate. And if there's pain indicated, that could possibly indicate peritonitis or appendicitis. Lastly, the Markle and heel jar, we would have the patient stand on their tiptoes and then drop down to their knees. And if there's pain in the abdomen, that could possibly indicate appendicitis. And that is the end of my abdomen exam. Thank you.